Good morning everyone, I'm Donna Gairns and I'm from Lymphoma Australia, and I'm joined here today with Michael Dickinson from Peter MacCallum Cancer Centre, and unfortunately we're going to be at EHA, the European Hematology Association conference in Frankfurt, but we're all stuck in Melbourne in our home countries, but it's really good to be able for you to catch with us today.
Thanks, Donna. It's certainly been pretty strange attending an international conference via Zoom. It takes a bit of motivation on a weekend, but it's been very good actually, and it's opened up, our capacity to actually spend a bit more time looking at the data and thinking about it, which has been perhaps a little easier than the face-to-face conferences.
Yeah, I think you're probably right. We actually have that time and that headspace, because usually at conferences it's so crazy. We're running around and meeting people and networking, and it can be quite entertaining. So good point. But thank you for joining us. And Michael actually had a presentation at EHA, which we're going to be talking about in a moment. But it'll sort of lead into your trial. I thought we might just sort of talk about a drug that's coming out in different studies around the world, and it's getting more and more attention as the bispecifics for use of lymphoma. Could you explain a little bit about what bispecifics are and what lymphomas they can be used in?
Yeah, sure. So bispecific is just a term that refers to how the drug works. So bispecifics are a class of antibody drug that have two targets. So they're specific for two proteins on the surface of their targets. One of those proteins is, in the case of the bispecifics we're talking about, is CD3, which is on T cells. And then a B cell marker, and for most of them so far it's been CD20, which is the common B cell marker that is targeted by drugs like rituximab and obinutuzumab. So the class of agents that's leading the bispecifics are these CD20, CD3 class of targeting agents, but there are bispecifics that have lots of other different targets as well that are coming through. In this particular case, by targeting T cells and B cells, what they're designed to do is switch on T cell activity and kill the B cell target. So in this case, we know that a lot of the drugs we use in B cell lymphoma target both normal and abnormal B cells by targeting CD20. Here, we're bringing our healthy CD3 positive T lymphocytes close to the B lymphocytes, which are the cancer lymphocytes in B cell lymphomas, and switching on those T cells to kill those lymphoma cells in a way that's not all that dissimilar to how CAR Ts kill cancer cells. So we're harnessing the immune system and indeed CD3 positive T cells in a way to kill cancer cells. And so what I was happy to be able to present at the EHA meeting were some updated results on a drug which now has a name. We used to call it CD20 TCB because it was a CD20 binding T cell bispecific. Now we call it glofitamab, and so it's a new name that's just been released, but it's still a drug that's in phase 1 clinical trials, and I reported some updated data from a phase 1 clinical trial that we were lucky to be involved with right from the very earliest of patients. And that trial has now recruited around 190 patients globally. And we started at doses as low as 5 micrograms and worked all the way up to doses as high as 30 milligrams. And I presented some data that suggests that these drugs are not only active in diffuse large B-cell lymphoma and follicular lymphoma and other subtypes of indolent lymphoma, but the activity can be sustained when you stop the drug. So we now have longer follow-up. So what we saw was that in diffuse large B-cell lymphoma, which is our common aggressive subtype of lymphoma, which can be cured in most patients when it presents with standard chemotherapy, but around a third might relapse. And of the patients who relapse, we're able to cure a significant fraction with autologous stem cell transplantation. But if you relapse after an autologous stem cell transplant, or for reasons of fitness or age or frailty, you're not eligible for the intensive chemotherapy that we use in autologous stem cell transplant, then we need something new. Now that's where CAR Ts have taken a place in different places around the world, and they're beginning to be more commonly used in Australia. And this trial of glofitamab targeted that same group of patients in need, some of whom indeed had CAR Ts before. And what we saw in a patient population which was enriched for the aggressive subtype of lymphoma was that there was quite a high response rate from this agent.
Okay.
And we saw complete remissions in about a third of patients with diffuse large B-cell lymphoma. And once patients had that complete remission, they generally retained them even after the drug was stopped. We have around a median of only 10 months of follow-up for the overall trial. And only a subset of patients have been treated at doses that we think are approximate to where this drug will be dosed in the future. But this is nevertheless very promising evidence that we can take a non-chemotherapy agent that harnesses the immune system to put patients who have aggressive lymphomas into a complete remission for a significant subset of patients.
Oh, that's fantastic.
The only other single agent that I'm really aware of that can do this is CAR Ts. But CAR Ts are hard to access, they're very resource intensive, and we're only just building our CAR T services in Australia. The attraction of this drug is you don't need to wait for the CAR Ts to be manufactured, and it can just be taken off the shelf and used if and when it ultimately becomes available. Now, it's too soon to know whether this drug will become available, and it's important to note that there's actually multiple drugs in this class that are being assessed, and we've seen presentations between Lugano last year and ASH and then EHA of multiple drugs. Another drug made by the same companies called mosunetuzumab, which has been in trials around Australia. We've seen particular activity there in follicular lymphoma and perhaps a more gentle safety profile. But there are also many other companies that are making these anti-CD20 antibodies, and a few preliminary results were seen at EHA. There's one company which is bringing clinical trials to Australia called Genmab, which is taking a subcutaneous route to deliver rather than intravenous.
Oh, great.
One of the things that has glofitamab being a little bit different is that it's easy to mix with other anti-CD20 antibodies. And mosunetuzumab is another drug which has shown some activity. So I think we're seeing the birth of a new class, and I think that was indicated by the fact that one of the sessions was called CAR Ts and bispecifics. So they had a whole session on this, and indeed there's more conversations being had in the coming days around this as well.
Oh, it's fantastic. And as you touched on, it doesn't need, it's off the shelf. You don't need all that time for a CAR T to be able to be administered. So it's much better for patients. And I'm assuming all subtypes of lymphoma this might be good for? Or?
Well, B-cell lymphoma,
yeah, all B-cells,
firstly. I think it's really important to emphasise that these are preliminary phase 1 clinical trial results. And we're still evaluating efficacy, meaning response rates and durability of response, but also safety. And we're still undergoing that. And it's too soon to say that this will necessarily become routinely available in Australia, but there's certainly enough information to say that this is a promising class of agents. And it was very exciting that in Australia we're able to access these new treatments through clinical trials. This particular clinical trial allowed B-cell lymphomas, allowed a range of B-cell lymphomas, but it's now being refined down to follicular lymphoma and diffuse large B-cell lymphoma. But there are bispecifics in Australia in clinical trials that are exploring lymphomas beyond follicular lymphoma and diffuse large B-cell lymphoma.
Oh, it's fantastic news for lymphoma patients that these new medications are coming out. And did they have a good safety profile as well?
Well, I think one of the things that might differentiate the different agents is the safety profile as well as the activity profile. There are other things that differentiate drugs when they come to market, as you know, like price and availability and listed indication. But just on the preliminary data, there does seem to be some difference in the toxicity profile. Generally, because these agents activate T cells they have adverse events that are similar in quality to the adverse events of CAR-Ts. So we were worried about cytokine release syndrome, which is this syndrome of fever and infection-like clinical presentation, fast pulse rate, sometimes a need for intensive care. But we saw this mostly as grade 1 and grade 2, meaning manageable, in this clinical trial of glofitamab. And we were able to manage that fairly routinely. But it's fair to say that we're still routinely admitting patients for the first 48 hours after their first hospitalisation with this drug.
Keep a close eye on.
After the first dosing of this drug, just to keep an eye on everyone,
Yep.
because you don't know who's going to get the fever.
Yeah.
We didn't actually see a lot of neurotoxicity at all. And the other thing to say is that only 3% of patients discontinued glofitamab because of toxicity.
Oh, that's good.
So when we compare that to CAR-Ts, it seems to be generally better in terms of the neurotoxicity profile, but a similar range of presentations of cytokine release syndrome, but at the doses we're using, more manageable. And the other thing, of course, is that our ability to aggressively manage side effects is just a little easier with drugs than CAR-Ts, because some of the things that we use to manage these toxicities are more readily deliverable when a patient's had a drug. And so by way of examples, we might hesitate a bit with steroids, with CAR-Ts, because we worry about dampening down our expensive new treatment. With these drugs, we feel a little less hesitant to use steroids. So I think all of that affects how we interpret safety profile.
Fantastic.
And certainly for the GenMab data, it appears to be on very small numbers, a safe product.
Well, it sounds very promising. And these patients would probably maybe open then to have CAR-T. It's safe to have CAR-T and things like that down the track if they happen to relapse, or
there's no
nothing
suggestion that it would impact upon the safety of CAR-T. I think that what we will learn as these new drugs come to market, particularly ones that harness the same mechanisms of action of T-cell fitness and T-cell killing, is that we have to be very careful about how we sequence our treatments in lymphoma. Previously, when all we had was chemotherapy and antibodies to combine with chemotherapy, you could, in theory, give things in a fairly well-established sequence. R-CHOP, platinum-containing second-line therapy, autologous stem cell transplantation, gemcitabine-containing chemotherapy. They're the sort of routine steps in diffuse large B-cell lymphoma that we might sequence treatments. Now we've got emerging therapies like the possibility of bendamustine and polatuzumab being approved in years ahead, and certainly clinical trials assessing that combination in Australia. We have these bispecifics that activate T cells, and I think we won't know for some time whether a bispecific treatment given before a CAR T cell treatment is needed affects whether the CAR T cell is any good.
That's going to be my next question.
And we have some reason to think for autologous CAR Ts, where we're making lymphocytes from a patient's own blood, that we might not want the bispecifics in a patient at the time we collect those lymphocytes, because they may change the way those lymphocytes behave when we're trying to genetically modify them to turn them into CAR-Ts. Pretty complex ideas, and it's all theoretical at the moment.
That's a very exciting time for you.
But the answer to it's exciting time because we're seeing all of these treatments come, and we're having to think about these problems. And the question that you asked, such a straightforward question, is one that we really don't know the answer to yet. But it's kind of exciting to think that we're beginning to see a series of active treatments for patients with relapsed diffuse large B-cell lymphoma, which is one of my personal research interests, and that the principles that we establish in aggressive lymphoma will probably see carry through to indolent lymphomas like follicular lymphoma and other low-grade B-cell lymphomas.
Oh, that's fantastic. And the presentation you provide was in a session, as you mentioned, with bispecifics and CAR T cell therapies. There was one study that was presented by Wendy Osborne from the UK about the Alexander study with Auto3. Would you give me a little bit of a rundown on how that works? That's really quite exciting, with similar sort of thing with bispecifics.
So this study was an initial presentation of a relatively small cohort of patients in a phase 1 clinical trial. And it's trying to address two issues with CAR T therapy that we know. So we know that CAR T therapy is an active treatment in relapsed diffuse large B-cell lymphoma, but it only delivers durable responses and cures to a significant minority of patients. It means that most people who get CAR Ts will not have durable responses to those CAR Ts that are routinely available at the moment on the market under market approvals. And there are several possible reasons why those CAR Ts these first to market CAR Ts that we have might not work in an individual patient. One mechanism of escape that we've seen is loss of the protein on the surface of the B cell that the CAR Ts are targeting. So we talked before how bispecifics that we're using target CD20. Well, most of our CAR Ts target CD19, which is also on B cells. And we know in B-cell leukemia that the tumour itself can change its spots and make itself invisible to CAR Ts by losing CD19. The other thing that we know, and I talked a bit about it before, about this idea of the quality of the T cells changing, is that it might be that autologous CAR T cells that are manufactured from a patient's own lymphocytes might just get exhausted. They just run out of puff. And they're there and they target their target, but they just don't kill the lymphoma. And so this trial decided to try to get around that with a new CAR T that had a new treatment protocol that had addressed these two potential mechanisms of treatment escape. One is it was a bicistronic CAR, meaning that it was targeting both CD19 and CD22, both on the presence of B cells. So that might get around the leopard changing its spots. Now, we think the leopard changing its spots is more of an issue in leukemia than lymphoma, but we just don't know, and there's certainly some early reports in lymphoma where the lymphoma can change its spots. But the other thing that they did in this trial is they added in a drug, a PD-1 inhibitor, which was designed to overcome T-cell exhaustion. So this is a complicated idea. PD-1 inhibitors are used in lots of cancer contexts, and they're approved in Hodgkin lymphoma in Australia in terms of blood cancers, and there's been a recent positive recommendation for the use of PD-1 inhibitors in primary mediastinal B-cell lymphoma, but it's not a treatment that we use in most of the lymphomas that we use, that we see. How do these PD-1 inhibitors work? Well, they basically de-repress T cells. So a tumour can express markers that stop T cells from killing it, and PD-1 inhibitors interfere with that. Now, in this trial, what we know is that the lymphocytes express markers of exhaustion, which are pretty similar in their manner to these other markers that we see on tumours. In fact, they're the same. And in this context, we throw in the PD-1 inhibitor to try to deal with exhaustion of the lymphocytes. And so in this clinical trial, I think the key, it was really just tantalising proof of concept that, that you could deliver this combination safely. And there was a pretty good response rate, for, roughly akin to what we see for standard CAR T therapy on the preliminary data. It's early data, but it's a nice kind of proof of concept of how we might get around these mechanisms of resistance. There's a whole lot more work that needs to be done by that group before we'll know whether this is something that carries forward. It's way too soon to say that this is better.
Oh, it's very
but
exciting.
Conceptually, it's interesting.
There's so much work going around CAR T, and we've got to remember it is still quite early compared to some other sort of treatments. So there's so much to learn, so watch this space. I guess it's probably timely to ask you a little bit, because you're leader of the CAR T cell therapy at Peter Mac, to see where we're at with CAR T in Australia and how far off manufacturing.
As you know, in the acute lymphoblastic leukemia indication up to the age of 26, we've been using CAR Ts for quite some time in Australia now. in diffuse large B-cell lymphoma, we've really only been routinely using it since about March. And at Peter Mac, we have a service which is made up of a number of consultants with a range of disease specialties and interests across leukemia, lymphoma, myeloma, indeed solid tumours as well, in a CAR T team that's essentially trying to learn the ropes with managing these toxicities safely and managing the mechanics of delivering CAR T well. Right now, Peter Mac is the only hospital that's routinely delivering treatment for patients with relapsed diffuse large B-cell lymphoma, which is of course, our interest here today. And in that context, it's approved for patients who've had 2 prior lines of therapy, who are not eligible for autologous stem cell transplantation, or patients who've relapsed after autologous stem cell transplantation.
Yep.
And the current approval allows most people with diffuse large B-cell lymphoma, but there's a specific note that it also allows patients with primary mediastinal B-cell lymphoma and transformed follicular lymphoma to be treated with CAR Ts as well.
Fantastic. And if people are interested to know if they'd be eligible for these, the CAR T, well, how should they go about that?
Well, the first thing to do is to ask your own haematologist for their advice, because I mentioned before that CAR Ts are active in a significant minority of patients. Clearly a treatment that we want access to and want to be able to deliver to people routinely. There is, I think, a little bit of a potential bottleneck. Now, we've not struck a bottleneck yet, but a potential bottleneck by the fact that there aren't enough treatment centres geographically distributed throughout Australia yet. But I know that my colleagues in other states are working very hard on this, and we already know that some hospitals across states outside of Victoria are on the brink of opening up treatment for patients with diffuse large B-cell lymphoma. But I think if you're a patient who's had more than one relapse of diffuse large B-cell lymphoma, you should be talking to your doctor about options. Excellent. There's 2 reasons. One, the standard of care CAR T, and the other, clinical trials. And we've got clinical trials that look at patients in their first relapse. We've got clinical trials that look at patients with nasty presentations of diffuse large B-cell lymphoma, where the initial 1 or 2 cycles of treatment aren't doing what we expect them to do. For example, we have a trial called ZUMA-12, where if a patient has 2 cycles of chemotherapy and they're not in complete remission, they can just have CAR Ts. And I think that is a daring trial. I think patients who volunteer in a trial like that are daring, but I also know that when that happens, I worry about the ability of standard chemotherapy to cure in as many people as I would like, and so I love having access to that trial. But all of these things require an inquiring mind from patients and from their haematologists, because of course it's very hard for us to reach out to everyone and tell them what's open. But we certainly take referrals from interstate.
Excellent.
We certainly work very hard to try to make sure that we provide any haematologist who asks for the information.
Brilliant. You can always give Lymphoma Australia a call too to put you in the right direction as well. Just to finish off, there's a couple of really good plenary sessions at EHA over the weekend related to Hodgkin lymphoma, classical Hodgkin lymphoma. The first one was a presentation by Professor Zinzani talking about the Keynote 204, which will possibly be a bit of practice changing in Australia. Yeah,
look, I think so. So Keynote 204 was an important industry-sponsored clinical trial that was run at a number of centres in Australia, and Robin Gaziorowski from Sydney is a co-author on this. It was, at the time we ran it, a very interesting question because we know that in Hodgkin lymphoma, again, most patients are cured with standard chemotherapy. Indeed, a really good chunk of patients will be cured by second-line treatment and autologous stem cell transplantation. But there is a group of patients who relapse after autologous transplantation, and there's a group of patients who are refractory to standard chemotherapies, despite everyone thinking this is a good prognosis disease.
It's roughly about 10%, Michael?
Yeah, it's roughly that, but I would say that, it depends a lot on how intensive the chemo was. So the answer to that question is a bit variable, but it's a minority. It's a clear minority who do badly after chemotherapy or not as well as we like. So this clinical trial said, well, what about novel agents? And we knew at the time that we were conducting the clinical trial that there was evidence that pembrolizumab is active in Hodgkin lymphoma and could deliver durable complete remissions or durable responses, if not complete remissions. Yep. So you don't even need a complete remission to benefit from drugs like pembrolizumab, to a significant group of patients where chemotherapy was no longer useful. And we also knew that brentuximab vedotin, which is a antibody conjugated drug, could also deliver complete remissions in patients who were refractory or who had relapsed after chemotherapy. So just as a reminder, pembrolizumab is one of those PD-1 inhibitors that we were talking about before. So immunotherapy versus a drug with a target, it's like a targeted payload to the treatment. Which one should we use first? They're both approved in Australia, but they're only approved in patients who've had several lines of treatment. Which one should we reach for? And this was a randomised clinical trial that tried to address that question. Now, I'm just going to refer to my notes briefly to make sure the numbers I give you are right, but there were basically what was presented was a second interim analysis. And this was presented at both ASCO and EHA. And there were 300 patients recruited, roughly, on a one-to-one basis to receive either pembrolizumab or brentuximab vedotin. Only about 5% of patients had had prior brentuximab vedotin, and about 27% had prior autologous stem cell transplantation. And what we saw was that there was a very significant difference in progression-free survival between the two arms in favour of pembrolizumab. Patients were much more likely to be on pembrolizumab at 1 and 2 years of observation than brentuximab vedotin. There was a different toxicity profile, as we already knew from the previous treatments, the previous trials in this area. And it was fairly clear to me in the data that pembrolizumab is possibly, you always have to be careful with these subgroup analyses, possibly particularly useful in patients who were particularly chemo-refractory. So there was definitely a leaning there. Now, I think this data make me want to lean towards that in patients who have chemo-refractory Hodgkin lymphoma, but we know that brentuximab vedotin is active, and we know the toxicity profile is often a very good reason that a haematologist might choose one drug over the other. And so I think it really depends on the context of the patient which drug we would use. It doesn't mean that it's wrong to reach for brentuximab vedotin. It just means that in all comers, perhaps the default would be to reach for pembrolizumab first. That would be my take on this data, and I have to add that I'm an investigator on the clinical trial, so I have a particular interest in the outcome of the trial.
Excellent. Very good results though, and something to think about.
Yeah.
And just finally, just the last plenary session that was with classical Hodgkin as well, from the German study group, talking about unfavourable early stage Hodgkin lymphoma.
Yeah. So the early stage Hodgkin lymphoma is really hard to understand and to teach and to practice in, because it's the most common presentation. So most people present with early stage Hodgkin lymphoma. We know that radiotherapy is an active modality. We know without a shadow of a doubt that the combination of radiotherapy and chemotherapy is better than radiotherapy alone. What we really don't know is how to optimise outcomes, or what we didn't know is how to optimise outcomes where you had the best possible rate of cure and the lowest possible rate of long-term complications from the treatment that you're giving. The general crux of it is that people feel that late complications seem to be linked with the use of radiotherapy. But a lot of that vibe is based upon era of using radiotherapy that have passed. We've got better radiotherapy machines, we're better at managing our volumes. So we're probably generally much better at giving radiotherapy than we were 30 years ago, where all that data was generated. Nevertheless, there are patients who have stage 2 disease where the delivery of radiotherapy could be just very technically difficult and might lead to too much normal tissue being involved with radiation.
Yeah.
And therefore might lead to an unacceptable rate of medium and long-term effects from treatment, even if the lymphoma is cured. And we also know that early stage Hodgkin lymphoma can be very, very good prognosis or can be quite good. And so this trial was a trial that looked at taking patients with unfavourable risk, early stage Hodgkin lymphoma, meaning multiple sites of disease, a larger burden than the very low risk patients, and the definitions are quite specific. I won't get into those. And then if we use the German approach to Hodgkin lymphoma, which is to reach generally for intensive chemotherapy, could we omit radiation in patients who had a negative PET scan?
Yeah.
So this clinical trial, and there's some detail here that I won't plug into too much. This clinical trial randomised patients to receive or not receive radiation on the basis of a PET scan result at the end of treatment. They recruited over 1,000 patients, and to summarise, it showed that if you give 2 cycles of escalated BIACOP, which is much more intensive than standard ABVD chemotherapy that most haematologists reach for, 2 cycles of ABVD and have a negative PET scan, that you don't need radiation.
Okay.
Now you might say, well, that, most doctors reach for ABVD in early stage Hodgkin lymphoma, and there's evidence actually that you can use PET scan, omit radiation, and still have a good outcome with early stage Hodgkin lymphoma. But there's no doubt in my mind that if you take this data and add it to the data that we already had about the management of early stage Hodgkin lymphoma, that now we have the tools for pretty much any patient who walks in the room to sit down and give them a real evidence base about how to address pretty much every level of risk factor, every distribution of disease, every personal factor about, for example, we might handle a young woman who has a family history of breast cancer with lymphoma behind the breasts in a very specific way, where we really focus on avoiding radiation. And this just gives us another piece of information to deal with all of these different potential scenarios. Yeah. Now I think we pretty much have evidence to justify most mixes of chemotherapy, radiation, no radiation, most ranges of risk factors, most personal circumstances, to really tailor the treatment of early stage Hodgkin lymphoma. So in my view, it is treatment changing. In the view of some of my colleagues, it isn't, because they say, look, I would never have used escalated BIACOP in early stage. But you do see patients where they present with early stage disease and you think, this one doesn't look as good on a PET scan. I want to do something a little more stronger, or I really want to be confident that I've lost the smallest possible amount by emitting radiation, and I'm going to do that by turning up the volume on the chemo a little bit. This trial gives us confidence in doing that without turning up the volume too much.
Okay,
and
so you do
keeping
that in
treatment
practice.
shorter.
Oh, okay, and you do that bit in practice now yourself.
Absolutely.
Yeah.
Absolutely.
And that's really important. I guess you touched on, quite often these are younger patients, quite commonly, and those long-term effects, we're trying to prevent. A lot of studies are going into that to prevent these long-term late effects from the treatments, because you have a long life ahead of you. Yeah. But no, thank you, Michael. That's been fantastic insight. Would have been lovely to be in Frankfurt right now, but that's okay. Melbourne's good. But thank you so much for your time.
Pleasure. Good to see you.
Everyone.
Thanks very much.